Hi, my name is Kate Barlow, and tonight I'm going to be talking to you about oral motor treatment strategies. So a little bit about myself. I graduated from Boston University in '97, and I started practicing in the Boston Public Schools. I moved to Virginia and I continued to work in the public schools for a total of 12 years. I decided to go back and I got my post-professional master's and doctorate from VCU. In that time in Virginia, I tried 3 years of management. I worked in a children's hospital outpatient clinic. And since I've been back here in Massachusetts, I moved back in 2015. I have been teaching full-time at American International College, and I also work as a feeding consultant for Springfield Thome Early Intervention. I've had some trainings that I'm listing here at the bottom of my screen. Some other things that I do, I'm on the mentorship board for OT Without Borders, and I'm also the CDC's Act Early Ambassador for the state of Massachusetts. So some of the work that I do is promoting the Learn the Signs Act Early program. So if you are not familiar with this program, please email me after tonight if you're interested in finding more about the program. It's a wonderful, free, everything is free on the CDC website, and it's all about learning how we can promote early identification for children in the community. One of the things that is dear to my heart is I run an international mentorship program. We have about 14 countries currently, and I host a monthly webinar where I have different presenters come on different topics that are presented. And it's mostly for therapists in developing countries where they are the first in their country to be practicing occupational therapy. So I did list my OER page here. There's tons of free resources, some of them that I'm going to be mentioning tonight. After tonight's presentation, Allison will be sending you an email that has the link to this OER page for you to check out. And it'll also have this link that I have at the bottom of this page, which is a survey for pediatric OTs and SLPs that work in feeding. So some of the things that I've done so far in the area of feeding, I've presented at several different state conferences. I presented my ARFID research in South Africa at WFOT. I have presented previously at one of Therapro's Saturday sessions seminar series. I am presenting at the International Integrated Care Conference. It was supposed to be in Croatia in April, but due to COVID, it is coming up online in September. So I'll be presenting on feeding using a decision tree there. And I was also awarded a grant from Feeding Matters to do a research study. This is the one I have the link for below. I'm doing that with Dr. Paula Rabaey, and we're looking at pediatric assessment tools that are being used by OTs and SLPs in the area of feeding. So that's a little bit about me. And tonight, the course objectives here, I really want for everyone to understand the importance of screening all children for feeding difficulties. And then the other objective is to really apply treatment interventions for specific oral motor deficit areas. Okay, so what we're gonna do next is we are gonna take some polling questions. Mike. All right, thank you, Allison. Okay, so moving right along, one of the biggest things that I do is I talk to caregivers about appropriate foods for a child's age and chewing skills. So I have like two big takeaways from this evening, and this is one of them. And that's really that when you're working with children, really look at the child in front of you and where are they developmentally. So regardless of their age, their adjusted age, what are they able to do? And let's really look at their skills and let's recommend food that is appropriate for them to eat based on their skill level. So it's really important to know what typically developing children should be able to do at what age, so you can sort of help gauge where they are. But I really just find that almost 90% of the time, what I'm doing is making appropriate food recommendations. So we're gonna go through I sort of have 3 things that we need to cover before we roll into treatment strategies. So one is looking at jaw strength and what is typical chew development. So this is a refresher for most of you, I am sure, but let's just cover it again. So we have this munching pattern that develops 6 to 8 months, and around 6 months is when tongue lateralization starts to emerge. So what happens? So we have this hand reflex, and it starts to integrate around 3 to 4 months, and kids start grabbing toys and putting the toys in their mouth. And as they're, mouthing toys, what happens is the gag reflex starts to move back to the posterior 1/3 part of the tongue where it should be. And all of a sudden, your tongue starts to follow where the toys are going in your mouth. So it follows the stimulus, and the tongue starts to lateralize. And the more children chew on toys, which is wonderful, it really helps the development of that tongue lateralization. And for your chewing skills, what we see is this vertical chew pattern developing around 9 to 12 months for typical kids. So when we look at when is it okay to give a child a biscuit, typically you're going to see 9 months, and it's because of this development of these chewing skills. When we look at diagonal or lateral chew skills, I refer to diagonal chewing skills, we're really looking for typical children between 12 and 18 months. So processed foods are great because it requires a diagonal chew. So chicken nuggets, hot dogs, a lot of kids really love these foods around this age time, and it's great because they can chew them. The circular rotary chew comes in sometime between 18 and 3 years of age, and that is a huge span, a huge time span. And in working in the birth to 3 population, a lot of times is what I see is the child is around 12 months, and the caregiver is making chicken breasts, like making their homemade chicken nuggets, because the caregiver feels like they're pouring their heart into their child and they want the most healthiest foods for them, and they're cutting the food really small so that the child isn't choking. But what happens is the child really doesn't have the ability, the chewing skills to really chew meat, because meat is a muscle fiber, and you really need that circular rotary chew that you're not probably going to have before 18 months for a typically developing child. So a lot of times it's really important just to make appropriate food recommendations, ask what the child is eating, and really look at the child's skills. Do they have skills to really chew that food that they're being given? I just read recently a guideline for bite, and to use the child's pinky finger and look at their pinky fingernail, and that is the size of what the child's bite should be, looking at the size of their esophagus, and for chewing, what's the best safest size for a bite. So that is a way you can think about bite size, but also making sure that they're chewing food that they're able to chew. The second thing I wanted to go over is why is tongue retraction with lateralization so important for feeding? So this is one of those things that we just have to really grasp. We need tongue retraction with lateralization to put the food, when we first develop, we have that protrusion pattern that we use on a bottle or a sippy cup. And we need tongue retraction with lateralization when we start eating to really put the food back on our teeth for chewing. We need tongue retraction to properly drink from a cup or from a straw. And every sound in the English language, except for TH, requires tongue retraction. So tongue retraction is a huge part of development. And a lot of times, what I see is that children are really struggling moving into the stage 1 baby food. So they're bottle or breastfed, and the parents are really trying to move them into, using a spoon, drinking from a sippy cup or an open cup, really trying to make that transition, and they're really struggling and really don't have that tongue retraction. So this is one of the areas where I start, I should say. So this is a common problem. The third area that what I wanted to talk about is why is lip closure so important? So I'm highlighting these 3 muscles here, the orbicularis oris, the buccinator, and the superior pharyngeal constrictor. And why are those 3 so important? Is because those 3 muscles make up the muscular sling that we need for propulsion. So a slow-moving bolus is really increasing the risk of aspiration. So we need to have closed mouth. We need to have a closed mouth in order to build up the positive pressure to propel the food backwards. So the lips are sealed, the buccinators, they're so important for narrowing the cheeks. Narrowing that cavity also helps to build up that positive pressure to propel the food backwards. So they all work together, these three muscles, to really, we call it the muscular sling. You know, the lips are closed, the cheeks narrow, and we're helping to move the food backwards. So if you have a child who pockets food, you know, if you were to test the buccinator muscle, you're going to find that it's weak. And so if the child is pocketing, then we know that the buccinator muscle needs strengthening. And so that means the narrowing of the cheeks is a concern. And so what is the bolus propulsion speed? Do we need to really consider that? So just really keep in mind that we need this muscular sling for bolus propulsion. And so many of our children on caseload have that open mouth posture. And so when you see that, really start thinking, ooh, I can do so much for this child. I can really make a huge difference if I can get those lips to close. Okay, so those are the three things we really just needed to cover before we move on. So this is the second takeaway here for tonight. So children are supposed to be happy when they eat. It is a gift and a right to enjoy to eat. And so anytime that you have a child who is avoiding food, irritable behaviors around food, refusing food, there's a problem. In my 20 plus years of practice, I really strongly feel that there isn't a behavior problem. There's usually an underlying medical reason for why these children are really refusing food and these behaviors. So I feel as though if we can really treat the feeding problem, the behaviors will get less. So really just think about that for all the kids on your caseload. Maybe you work in outpatient and you have them for handwriting, or you see them in the school system and the child has CP and you haven't even thought about feeding yet. No one's mentioned a concern. Really, regardless of why this child is on your caseload, please do that feeding screen and find out what is going on, because the prevalence of feeding issues is so large that you most likely have children on your caseload that do have feeding concerns. And so we really just want to catch them. So keep in mind, all children should be happy when they're eating. So what is the prevalence? The research varies depending on what article you're reading, but for typically developing children, usually what I read is about 25%. So 1 in 4 toddlers are going to have feeding difficulties. For premature infants, it can be as high as 70%. For children with developmental disabilities, as high as 80%. And I recently read an article about children with cerebral palsy, 99% have feeding difficulties. So if you're a pediatric OT or SLP, you're going to have children with feeding difficulties on your caseload. Here is just some more research talking about the different numbers and percentages of children with difficulty. So I just hope that everybody is screening all children for feeding difficulties, regardless of whether or not that's the reason why they came to you. If they come with a script for visual perceptual difficulties, let's at least screen them or ask the questions to the caregiver about what's going around mealtime. So this article came out in 2019. Pediatric Feeding Matters is really trying to develop a universal definition of pediatric feeding disorders. And so this is the definition that they have: impaired oral intake that is not age appropriate and is associated with medical, nutritional, feeding skills, and or psychosocial dysfunction. And this is a great framework. If you haven't yet seen this article, please look into it. I really like the definition and the framework that they have. And they're using the World Health Organization's International Classification of Functioning, Disability, and Health. The article really stresses the importance of using a team approach for intervention for feeding. And the 4 different domains of pediatric feeding really speak to all the areas that we need to address when we're looking at pediatric feeding disorders. So the 4 domains, medical, nutritional, feeding skills, and psychosocial factors, I sort of went ahead and put them in my mind about how I look at children, and a lot of times how I see them as far as, you know, I have children who have oral motor issues. I see children who are sensory picky eaters. I have children who are the avoidance, you know, refusals. And then I have children who have a lot of postural mechanic issues. And so taking those, the sort of the 4 areas, although posture can go into some, that can play into many of them. The children who have oral motor skills, if we're looking at the domains of PDF, they're going to have feeding skill issues, and they're going to have nutritional factors. The sensory, children with sensory issues, the picky eaters, right? A lot of times it's feeding skill, psychosocial factors, as well as nutritional factors. You know, how many foods are they eating? Are they eating more than 10 foods? For kids who are absolutely in the food avoidance, there's medical issues usually, there's psychosocial factors for sure, and nutrition factors. So I've seen a bunch of kids within the last year who eat 3 to 4 foods, but they're not underweight. So there's large nutritional concerns, and they're not being given Pediasure because they're not underweight. So there's just this big area of nutrition that is a huge concern for these children. And then you have your children with physical disabilities where posture can make such a huge difference. If the muscles are not in neutral, they're not at optimal functioning. So, you know, do they have a hyperextended neck that is just increasing the risk of aspiration? You know, are they in that 90-90? What is their pelvis doing? If they start to choke, do they have enough room to move forward? So really looking at posture can be really important, especially for oral motor. So this is a pediatric feeding disorder decision tree considerations that I put together, and I really put it in these 4 different domains, sort of Kate's domains. And I think it's important just to have this as something that you are considering when you're doing your evaluation. So let's focus on these oral motor skills. What is the trunk doing? What is the neck doing? The jaw, lips, cheeks, tongue? Is there a possible tethered oral tissue? Has the family already tried thickened liquids, or has this been recommended already? If we're looking at avoidance, why is the child avoiding food? Is there a history of reflux, constipation? Has the child been tested for allergies? Is there stress? Is this child have a history of complex trauma, and the child has so much cortisol piping through this system that the child is just not hungry? Is there a history of aspiration? Is there possibly PANDAS, the pediatric autoimmune neuropsychiatric disorder, right? PANDAS. Is there a history of strep? And so we need to possibly consider PANDAS. Is there any liver or renal failure? We know, or function difficulty, we know that that can cause problems with food refusal, or possibly EOE. If we're looking at sensory picky eaters, I always make sure that I have that list from day one from the caregiver, and I divide it up into what the child always eats, sometimes eats, will not eat, and used to eat. I need to get that list right away so that if I increase by at least 1 food, maybe 2, I know that I'm already showing progress. I want to make a list of 5 target foods, foods that the family, foods that is already being eaten in the house. I want to know what the mealtime routine is. You know, is the child even sitting at a table, or is the child walking around with, you know, a plastic bag of goldfish throughout the day? What is the daily schedule of activities? And I always want to ask about the brushing of teeth. So if those of you who know me know this is one of my big things, because if children have oral motor issues, avoidance issues, or they're sensory or picky eaters, brushing teeth is a lot of times a huge problem for the parents. And so we really want to make sure that they have a good brushing teeth routine as part of the evaluation. And we also want to look at the posture and mechanics. How are they being fed? Do they have a feeding chair? you'd be surprised sometimes the way children are being fed it, and I would have never even imagined that if I hadn't seen it with my own eyes. For children with physical disabilities, has the caregiver tried sideline yet? Sometimes it can really help with lip closure, and you can get good straw drinking out of sideline. What is the adaptive equipment that's been tried or used? When we're looking at aspiration possibilities, have we monitored the respiratory rate, the oxygen saturation, temperature, really getting some of those objective measures to see if there's possible aspiration happening? What is the food consistency? So has the food already been thickened? The new IDDSI framework has a really nice guideline so that everyone's using the same terminology for modifying foods and thickening liquids. Has the child already had an MBS? So please feel free to use this as sort of decision tree. And of course, for all children, is the child below the 5th percentile weight? It's really important to know that, so we make sure that we have a nutritionist on board if we need to. So I'm going to take a break right here and stop. If anyone has any questions, please feel free to ask.
Kate, I'm not sure if you're seeing the questions coming in, but there is a question on mouth breathers and how you promote lip closure.
Oh, yeah, sorry, I'm just learning how to view the questions. So one of the things about mouth breathers is really kind of why are they able to breathe through their nose properly? So sometimes kids that have a lot of allergies or just have constant stuffy nose, they're not able to breathe through their mouth really well. So I really want to start with, why are they breathing through their mouth? And we're going to come up on some exercises for lip closure in about 4 slides. So I will definitely cover lip closure in just a minute. And if I don't cover your question, please get back to me. We are going to cover most of the issues about oral motor tonight rather than sensory issues. Yes, a question is the MBS a modified barium swallow? And yes, that is what I was referring to. I am sorry about the abbreviation. Another question is, can you explain more about side lying and encourage lip closure and straw drinking? So if you have the luxury of not being an EI and you're an outpatient or in a school system, and you can get one of those like large wedges, and you can put the child on one of those large wedges, and sometimes they have like those Velcro straps, so you can really get a child in a good position and sort of have them so that their head is up. Sometimes in this side lying position, you can get really good lip closure and straw drinking. So if you have a child that has like that more severe disabilities and you're having trouble with lip closure and drinking is a concern, it definitely warrants just trying it. It doesn't work for all children, but for some children, it can be really beneficial. Okay, so your assessment is the most important part of the treatment, because without a good assessment, you're not going to have a good treatment plan. So we really need to find out what are the specific deficit areas that is causing the problem. So when you're interviewing the caregiver, I always remember the 3 Ps. So that's past medical history, pain, and poop. So what is the past medical history? Is there a history of an NG tube? So we're going to think oral aversion. Is there a history of reflux? And so we're already thinking, oh, what goes along with that? Were they on medications? Was it successful? And pain is really important, because I really don't feel as though feeding therapy is successful when there's an underlying pain issue. I just don't feel like we can fight pain. Children, they will just refuse to eat. They don't eat when they're in pain. They don't eat when they're not hungry. They're not like adults. And so if the caregiver feels like the child is in pain, that is really what needs to be addressed first. And it just has been my experience that feeding therapy is not successful and just doesn't beat pain. Next, I try to assess the oral motor skills. So I'm looking at the range of motion and strength for the lips, jaw, the cheek, and the tongue. I'm going to ask the child to feed themselves if they can. If not, I'll have the caregiver feed the child. So I'm getting to see all the dynamics at play. I'm always looking at their skills, the posture. What are they using? Is it a bottle, a sippy cup? What are they using for utensils? And then when appropriate, I'm doing a sensory assessment. So what will the child touch? Is a sensory profile appropriate? So when I'm doing my oral motor assessment, I'm using the Beckman Oral Motor Protocol. I'm not sure what everyone else is using, but when I refer to the oral motor assessment, that's what I'm using. But I wanted to bring your attention to, there is a bunch of free feeding screening tools available on this website, feedingflock.com. And this is one of the websites that's on my OER page that's going to be emailed to you. So you can just click the link versus then writing it down. But these are some great free feeding assessments with the PDE, the CHOMPS, the FAM feed. So take a look at these. A lot of these are parent questionnaires. The EFS needs to be completed by a clinician, and there are different age ranges, but these are some great tools, especially if you are a beginning therapist and you're really not sure where to start, or you're not feeling very confident in your skills to sort of come up with your own impromptu evaluation. These are some great tools that are available to you. All right, so let's talk about the oral motor assessment and really why we need to know exactly what's happening in the mouth. So lip closure and strength. The lip closure, again, is so important because we need it for that bolus propulsion. We need to close the mouth to build up that positive pressure. About 50% of kids with cerebral palsy drool, and about 80% of kids who use a straw don't drool. So if we know that we have a child on our caseload who has an open mouth posture, who is drooling, let's get them with a closed mouth to prevent that drool, which has huge psychological implications because drooling is just not socially appropriate. If you're at a preschool and you're still drooling, it's going to be trouble making friends. You know, by 18 months, children really shouldn't be drooling anymore. Maybe they break a tooth, okay, that's one occasion, but really drooling should not be happening after 18 months. So if you're working with a child that's drooling, there's work that can be done, and we can do it, right? We just need to know how to do it. And one of the big things that we can do is get them straw drinking. Diane Barr says to start straw drinking at 6 months. So this is great, right? Let's look at the lip closure and let's look at that strength. We also want to look at gum massage. So I was talking a little bit earlier about how, you know, if you're not chewing on toys as a baby, that gag reflex is going to be all the way at the front of your mouth. So when I'm gloved up and I'm assessing oral motor skills and the child allows me to put gloved hands in their mouth, I'm going to do that gum massage, because if the child has an issue, they're going to pull their cheeks in so tight, and I'm not going to be able to get my finger back. And doing that gum massage is one of the ways that we can help with the gag reflex if that's an issue. We want to test the posterior cheek strength. We know these buccinator muscles are so important for decreasing pocketing, for building up that positive pressure, right? Keeping the food on the teeth. Deborah Beckman says you need 3 out of 5 posterior cheek strength or it's not safe to be chewing food. So let's really take a look at that cheek strength. We need to look at the tongue range of motion and strength. So the tongue, can it move side to side and lateralize? And it's important not just for the range of motion for the tongue, but also for the strength. Does the tongue have the strength to really push back against that posterior pharyngeal wall for that positive pressure that you need in order to propel the bolus back? So the tongue has to be strong enough to really, you know, build up that positive pressure. So the tongue needs to have strength, not just range of motion. We want to look at jaw strength. So jaw strength, this is, you know, when you're working on the jaw, I feel like the jaw makes the fastest progress, right? So it's easy to see if people are doing their homework with the jaw. But the jaw strength is so important for chewing. So if you're working with a child and, you know, if you cut up one chicken nugget into 6 pieces and it takes 20 minutes to eat one chicken nugget, how many calories were just burned by chewing that one chicken nugget? So we really want to look at the jaw strength. Do they have the ability to chew the foods that are being given to them and in a good amount of time? And we also want to look at motor planning. So if you are looking at a child and you see that they have motor planning issues with their coordination of their body, gross motor skills, then that's a good indicator that they're probably going to have gross motor planning problems with their mouth. So that's going to impact their speech articulation, but it's also going to impact their ability to have a quick bolus propulsion. You know, can they make the bolus and can they propel it back, which should be in one swallow. So motor planning is a really important part of your assessment. So when we're talking about treatment interventions, now that you've got your area of assessment, you know exactly what muscles you're targeting because you know the specific deficit areas, this is how you have a successful treatment, right? So when I first started, I was like bubbles and whistles for everybody that had any oral motor issues because I didn't really know how to tell what was the jaw versus the tongue versus the lips. I really didn't have that ability to really do a good assessment. So a good assessment is really the key for a targeted intervention in order to be successful. In order to be successful, we also have to keep in mind that most of the muscles for swallow are type 2 muscle fibers. So what does that mean? We have to keep challenging the child. We have to use resistance. So if we think about our type 1 muscle fibers, you know, if we have the child blow on a whistle 10 times each time we see them, then we're never getting the type 2 fibers activated. They're never even going to pitch in. And these are the muscles that we most need for swallow. So really keep that in mind, that if we're not increasing the resistance and increasing the workload, the challenge to the patient, we may never be activating those type 2 fibers because type 1 is always activated first. So we have to keep upping the ante. We have to keep, you know, increasing the chew tube resistance, increasing the amount of times that they're chewing on it in order to keep that challenge, in order to really activate what the muscles that we're trying to target. So keep that in mind when you have your treatment plans. You also want to make sure that you're always warming up the patient first, just really making sure that they're comfortable and they're relaxed and they're in a good place. You never just want to put their hands in the child's mouth, or you may have a little hazard, maybe get bit. And you also want to make sure to always give control and choices to the child when you are able. Okay, so the rest of the presentation is going to be on your interventions, and we're going to start first with the lip closure activities. So a lot of times I'll start working with a child and they'll have like an open mouth, and I'll have them trying to blow kisses against the hand for homework. So everyone in the family, grandmama, everyone's going to be blowing kisses with the child. So they'll start with like that open mouth, ah, and you're going to hopefully try to get that lip into a purse, so eventually it's a closed mouth. I also, when I'm working with the child in treatment, I'll use like a Z-Vibe with these little animal tips on them. I love these things, and you can kiss against the vibrating animal tip. It gives a lot of input to the lips when it's vibrating. You can work on blowing through a straw. You can do little sparkle balls at the dollar store. It's amazing how much kids love these little sparkle balls that you get at the dollar store, but you can blow them off your hand or you can blow them through a straw. And every time you blow, you're getting that pursed lips. Your lips are kind of closing in, working towards that lip closure. I also work on straw drinking for lip closure. You see on the slide here, we have this little honey bear. I used to have this in the schools and in outpatient. It was great, a little bit hard to clean. My hand sometimes wasn't great at having a consistent squeeze. What I find now is I go to the dollar store and I get these tiny little juice boxes so that I'm not wasting so much. And I facilitate the child's mouth being closed, and I give it a little squeeze, and I teach straw drinking now through juice boxes. I'm also in early intervention, mind you, so I don't like carry honey bears around, but you can do a lot of good lip closure using the juice box. Okay, next we're going to do lip awareness. Again, I love the Z-Vibe. This is a different type of Z-Vibe, but the vibration really is waking up the lips. If you have a child that's drooling, we want to get rid of, or just always have this wet area here, you know, the lower lip and chin is always wet. We really want to work on that lip awareness, really help to get that lip closure. So I used to have a big cup, and I would fill it full of ice and water, and I would have all these plastic spoons, and I would put this plastic spoons in the cup of water like an hour before the patient I needed it for, and then I can really wake up the mouth and the lips with this really cold spoon. You can do fish faces in front of a mirror, putting all different fun, different frosting on your lips. So you can do blue lips, you can do orange, you can kiss the pumpkin, you can do bright red and kiss the mirror. It's really fun for kids to see themselves with these brightly covered lips. You can also put a Cheerio. I use actually Apple Jacks a lot because I feel like Apple Jacks are dissolvable, but you can put a Cheerio or an Apple Jacks on the lip and have the child really bite the Apple Jack off the lip. Just keep in mind that the ability to do that emerges around 18 months. You just want to make sure that your child is old enough that they would be able to do it if they had typically developing skills. For lip strength, blowing bubbles, blowing whistles, blowing windmills, party blowers. I get these party blowers at the dollar store, and the plastic ones are really great. The ones with cardboard are one-time use, but the ones with plastic, you know, you can put them in a plastic bag with the child's name on it, and you can reuse them a second time. Can you in some way give resistance to the lips? Is there a tool that you can use, the Z-Vibe, the spoon, your fingers, that where you're really giving that resistance? If you are blowing party blowers, remember you have to keep upping the ante. You have to keep challenging the patient so that you make sure that you're getting those type 2 muscle fibers to fire. So the Talk Tooth lip press might be my favorite activity. It's great. It's lip strength, right? So we know we're working on those type 2 muscle fibers. I used to raid the speech therapist closet when I worked in outpatient. They had the best tongue depressors, and they come in all different flavors. And that way I'm giving the child a choice of what flavor tongue depressor they want, and you put money on the end. So I would put like 2 pennies, and then they hold it for 20 seconds, and then 4 pennies, and then they get to keep the money. Kids are so motivated by money. I don't think you could do that in schools, but you could definitely do that in outpatient. And then the next time it's nickels, and the next, you get 4 nickels, keep the money, and then you're moving on to quarters. So you're constantly giving this resistance, and the children really enjoy this activity. Like, it's a no fail. It's great. I highly recommend it. The button pull is another good activity. I bought a big bag of buttons really cheap. They go through the dishwasher. I put dental floss through them and just throw that away when I'm done. You close the teeth and you put the button on the front, and then the child has to, keep the button there as you pull. The only thing about this exercise is the child has to be able to really be able to follow directions. So just making sure that the child is cognitively able to follow those directions. For jaw strength, chewies are so great, right? They come in all different colors. The yellow is the easiest resistance. The blue is the hardest. You are going to make progress when you work on chewing with these. And this is probably the fastest progress you'll see, like I said. When you're documenting, though, just make sure that you write what color. So you're working with the yellow tube today, or, yellow tube, and you had 6 out of 20 on this side and 4 out of 20 on this side. So if you started with the right side on Tuesday, make sure on Thursday you start with the left side, because whatever side you go first tends to be it performs a little bit better. So you want to make sure that you're keeping good notes. So you write down the color of the chew tubes to make sure that, if someone else is treating with the child, or just so you don't forget, if you have a really large caseload, what color resistance chew tube was I working on? And just make sure, again, that you keep increasing the challenge, just to make sure. Even with a chew tube, if you do the same, if the child is able to do 20 and 20 with the yellow chew tube and you never increase it, and the child still needs to make more progress, you're not going to see any, because once they can do that, if you keep doing the same thing, you're not going to be activating those type 2 fibers. Another activity is the lip prints play doggy. This can be a really fun exercise. I used to use face cloths, where the child can bite on the face cloth and you just pull, and you're like pretend like the child's a dog. I also do a lot of recommending gum chewing. So Talk Tools has a program for gum chewing. I'm a big recommender of this program as long as the child is cognitively able to follow directions, and obviously the caregivers feel comfortable with this. Sometimes caregivers aren't gum chewers, so I offer to spend a session really teaching them the program. But for those children that really crave oral motor and they're constantly like biting on their sleeves and their shirts, and the caregivers like, my goodness, they're going through all their clothes, they're ruining their clothes. This is a great, gum is also socially acceptable. So it's, some parents are really concerned about those chew necklaces, or they're not socially acceptable. So gum is just consider gum. Okay. I'm moving right along. Also for jaw strength, I use polyester organza a lot. So I went to Joann Fabrics years ago and I bought, well, I had a speech therapist friend do it for me, but she bought yards and yards of this polyester organza, and I still have it today. And I cut it up into, I have a little baggie, and I cut it up into squares using my kitchen scissors, and I go around and I give out the squares to parents to try. Because if you're not sure if your child can chew it, you can put it in polyester organza and you don't have to worry about it. So you can put the steak in the polyester organza and, and you can give it to the child and they can chew it and they get that flavor. And you're not saying no. If you're at the dinner table and your child has ground beef and everyone else has steak, and they point to yours and they want a bite of yours, it's almost heartbreaking, right? You want them to have everything that you have. Well, you can do it. You can give them the steak, and you just have to wrap it up and make sure it's safe. They also come commercially available, so how nice is that? I do find these feeders a little bit difficult to clean, so they're not ideal for outpatient or the schools, but for home, like EI, if the parents are using them, they have the time to really soak those and make sure that they're getting as clean as you would want them to be, and there's only one child using them. And they can just give the child the steak in this feeder, and they can be independent at the table, really chewing on it in a safe way. So I am, like I said, I'm a huge fan of this, but again, you're also trying, it's really hard sometimes when you're trying to move from like the biscuit to the chicken nugget, or you're trying to move from the chicken nugget to the chicken breast. You're moving up a stage of food, and it's a little bit nervous. A lot of times it's me, at the clinic or in EI, I'm the first one to really jump from the biscuit to the chicken nugget. And so you're doing it in that controlled environment. And so what a nice way that you can use polyester organza to really sort of make sure that the child is ready before you give them the actual food. So it's a really great strategy that you can try. I have tongue awareness up here because a lot of times with our kids who have, say, a Down syndrome or a low muscle tone, sometimes they also need tongue awareness. It's like their body needs to wake up for treatment. So you might bounce them on the ball, or you might do the cross crawl, or you might do some motor activity to sort of wake up their system before you work with them. In some ways that you can wake up the tongue and really wake up the mouth is listed here, like hot balls or Z-Vibe, the cold spoons, and a good recommendation for parents a lot of times is to spice up their foods. So some of the children we work with, when they go into the teenage years or even around 9, 10, sometimes children start to put on weight. And what people have found is they're not tasting the food. So if you add Tabasco sauce and you add garlic, sometimes that'll help control the weight because the kids are overeating because they're not really tasting the food. So really spicing up that food can help. So next is tongue lateralization, and I love this picture, and I'm going to tell you it's one of my boo-boos that I made as a therapist. So I was in Morocco and I connected with this child who's just a love, and the therapist, and when I came back to the States, the therapist and I were texting through WhatsApp, and she was asking me about the tongue lateralization, and I had recommended celery or carrot sticks because for some families you can say, yeah, you can get like a Nooks at Target, or you can buy this or that toys, but for some families that's not appropriate. So you can say use a hard hard carrot stick or a hard celery stick. So I didn't mention that they should be the size of like a Slim Jim. So when the therapist sent me this picture, I felt so horrible because, you know, she was so proud to like, look, I'm following your recommendations. And then I saw this child and I'm like, oh my goodness, that child's tongue can't move at all. Look at the size of the carrot. So I just remind myself that, you know, when I'm explaining things, sometimes I'm not clear, and I think I am. But your carrot stick and your celery need to be really thin and raw, and so the child can chew on them, and then it's going to be like a toy, and it'll cause that tongue to really follow the stimulus to the side and start that lateralization going. You can also use a mirror and play silly faces, you know, things like that. I use a Z vibe a lot, you know, follow the Z vibe, and I'll push against the tongue and kind of come over this way and see if the tongue will follow. I use a lot of lollipops. There are these little tiny lollipops that you can get at the party store or online at Amazon, and they're really like half the size of a dumbbell, which is really nice for our little mouths. So I'll use the lollipop to try to play tag, or Slim Jim to play tag, really trying to get the tongue moving side to side following a stimulus. You can also work on tongue strength that way. You can use a tongue depressor as well to really try to get some resistance exercises. For tongue retraction, I love using straws. So every time you suck in a straw, you're getting that tongue retraction. So it's beautiful. So at the dollar store, we have like these crazy straws, and I go to Moe's a lot. Welcome to Moe's. And they give away free cups with my Moo Moo Mr. Cow. And so here you go. You've got a therapy cup and a straw. And, you know, the child, can be working on tongue retraction. The big thing here about using a straw is to make sure that the straw is not placed on the tongue. And you really want to make sure that the child is not suckling the straw. So when a child is using a bottle or a sippy cup, the child has that tongue protrusion motion. And so a lot of times what they'll do is they'll just put their tongue on the straw and do that suckling motion as well. So you really want to make sure that you're giving the child no more than like a 1/4 of an inch so that you get that pursed lips to make sure that they're actually sucking and not suckling. Talk Tools has lip blockers, which if you see on the screen, it's that yellow thing right there that you can buy, that you can put on the straw to make sure that the child is not suckling that straw. This Talk Tool Straw program is really fantastic, especially if you're in an environment where the family can buy the program, because as the child moves up through the straw, you're showing progress, and you're just getting that tongue retraction. And it's not even like therapy, you know, like the child's just drinking and they're getting that tongue retraction. A lot of times I'll recommend a cup like this if the family is sort of moving off the sippy cup or off the bottle, because they can start to suckle this, and I just have the family slowly, it's like one of those rubber tops, and I'll just have them cut it so tiny that the child will never know, like every 2 weeks, just take a tiny little bit off. So even if they start to suckle over time, there's only going to be a tiny little bit left, and it's going to cause them to use that pursed lips. And then the straw will not be on the tongue. Blowing whistles or using the Talk Tool horn program is also fantastic, because every time you blow really hard, after you blow, you get that tongue retraction. So the Talk Tools horn program, again, if you're like in an outpatient setting, or I've even seen this used in the schools a lot, where the therapist will send the different horns home for homework, that's really great, because as the horns get more difficult, you're showing progress as well. When I used to use the horn program, I would buy like the cheap whistles at like the party store first and make sure that they stopped biting them and they could actually blow them before I would start the program, so I wasn't getting my nice whistles all ruined. But so just keep that in mind, that when children are really starting to blow the whistles, they're probably going to bite a little bit for that jaw stability, and your horns might get a little beat up. But again, great exercises for tongue retraction. For tongue tip elevation, this really emerges for typical children around 12 to 15 months. Again, just like tongue lateralization, I like to use a Z-Vibe or Slim Jim or Lollipop and really try to have the tongue follow the stimulus that I'm using in the mouth. Talk Tools has a great program called the Cheerio Hold Up. Again, I typically use Apple Jacks, but the child would hold the Cheerio at the roof of their mouth. And that's a great way to motivate them to do the tongue tip elevation. And for occupational therapy doing feeding, a lot of times I feel like this is like when the physical therapist gets the patient to walk down the stairs in a sniff, it's sort of a sign that they're ready for discharge. For me, when I was an outpatient, if the child could do the tongue tip elevation, usually that coincided with they had the skills needed to really eat safely, and I would a lot of times then refer them on to speech therapy for further articulation work. But tongue tip elevation is definitely a skill that you just want to work on in conjunction with your others. For cheek awareness and strength, we talked about the buccinators earlier and how important they are for building up that positive pressure for chewing and keeping the food on the teeth, narrowing that cavity. So how are we working on cheek strength? You know, are you doing resistance inside with maybe the Z-Vibe or your finger? You're trying to get resistance to those muscles. You're doing the Beckman stretches, or you're doing NMES. So neuromuscular electrical stimulation is so fantastic for the cheeks. Using this NMES vital stim it's the only thing I know of that targets type 2 muscle fibers. So they don't, you know, in all the exercises that you do, the type 1 muscles fires first and then the type 2 muscle fibers come in. But Vital Stim targets type 2 muscle fibers first. So it's really effective. It's evidence-based. The research is out there. When I first, I think 2009 maybe, when I first got Vital Stim certified, you know, it was sort of like, it was yes for everyone, for adults. For pediatrics, people were like, oh, I don't know, it's uncomfortable. Oh, the kids, you know, if they have oral aversion, they're not going to like it. And I felt like people had mixed feelings about it, but I don't feel that way anymore. And I just feel like it's so effective. It's research-based. We really need to be making sure that caregivers are aware that this is an option for their children, even if you necessarily, as a therapist, you don't know how to do it or you don't know much about it. Please just let parents know that it's out there and it's an option and give them the choice, because it can be really amazing for children in building up their strength for swallow. Okay, moving on. I went to this conference in January for Feeding Matters, and I'm just going to talk a little bit about what Rachel Rosen said at this conference. So she's a doctor, she is a professor at Harvard, and she also works for Boston Children's as a GI. And why I think this is so important to share with you is because I felt like this was new information and a new way to look at feeding that I hadn't heard. So what she was really talking about was how we're treating children and talking about aspiration. So she's saying only 20% of children that aspirate get pneumonia. And so even if they know that kids are aspirating, they want to keep the kids swallowing. They don't want to put kids on G-tubes or put them NPO anymore. So when I think back when I first started practicing, you know, it was like, oh, the child's aspirating, they go NPO, they're looking at a G-tube, and she's really trying to reduce the amount of G-tubes to only 5%. Which is huge. So I felt like this was like a total shift in the way looking at children. And even if you know a child is aspirating, continuing to swallow and work on that swallow to try to improve that swallow versus going NPO, which I think is really exciting for our field. So most of the children that you see that are more severe, that have these complex oral motor issues, I think this is really important information to know. She was also talking about to try to use homemade blends whenever possible for G-tubes or thicken the G-tube feeds. So I think about, oh, all those kids, the parents would always complain about the smell of the Pediasure, and it wasn't thickened. But right, like children with G-tubes still aspirate and have reflux, so thickening it really makes sense. She also talked about really trying to use homemade blends whenever possible. So Marsha Duncline and Suzanne Morris were way ahead of their times with their homemade blends book, which is at the bottom of this slide, but just really important new information. She also talked a lot about babies and seeing children that are just on breast milk or formula, and really going to thickening liquids first, and thickening the breast milk or formula as the sort of first approach for improving reflux and aspiration. And one thing she talked about was that they're seeing that reflux meds don't work for children that are just on breast milk or just on formula, because there isn't the acidic buildup that reflux meds really target. And so I just find this really just thinking about how we look at what our recommendations are. And so really thinking about thickening the breast milk, which you need to have a commercial thickener for, and you definitely need to have MD approval if you're thickening breast milk, or thickening the formula, and making sure that if you are thickening the formula, that you're really consulting with the nutritionist because of the osmolarity guidelines. If you make the formula too thick, then you can slow down the gastric emptying. So you really don't want to slow that down and cause other problems. So if we are thickening, we definitely need to be in consulting with a doctor or nutritionist, but really making sure that we're considering that when we have some of these problems, and looking to that first, which I think is exciting. Okay, so the last thing I sort of wanted to mention was infant massage. So I did get certified in infant massage years ago, and I recommend infant massage for almost all of the children that I see in feeding. I do tend to see more complex children now, but there's so many benefits to infant massage, and this is research, right? It improves weight gain, improves circulation, it boosts the immune system. But what I like best about infant massage is that it really helps with the bonding for the parent and the child, because most of the children that we work with, the parents are just like beat up. You know, it's so awful for the parents. Like their job is to like love, feed, and clothe their children, and they're not able to feed their children properly, right? So there's just a lot of defensiveness sometimes, and there's just, you know, there could be bonding issues. And this is something that's not about food, that the parents can do and can be successful and really have that time with their child. I recommend it even, you know, for older children, because, you know, for our children with physical disabilities, constipation is a huge issue a lot of the times. So why not continue to massage? Do the belly massage, do the arms and legs. It feels wonderful. So I don't feel as though we need to stop at any certain age. Maybe we just don't call it infant massage anymore. But definitely consider infant massage, and definitely for the kids who have a history of an NG tube, we know that that correlates with oral aversion. And so doing the facial massage is part of the infant massage can really help with that. So just consider the infant massage into adding it into one of your tools in your tool bag as a feeding therapist. Okay, we are going to take the poll questions, our post, to see if we learned what I was hoping you would learn tonight. So Allison will shoot those out for you.
Okay, we have the first poll question about swallowing muscles going out there. We'll let this one run for just a few minutes or a few seconds.
More for endurance, and our type 2 fibers are for power. So those are what most of the muscles of swallow are type 2 muscle fibers.
All right, let's go on to our lip closure. All right, so most people said all of the above. We have 94% saying all of the above, and
Great.
6% saying creating a positive pressure.
So the answer was all of the above.
Awesome, and then let's run the last one. We are talking about exercises. So we have the big winner is 58% saying tongue depressor with increasing weight for lip strength.
Correct. That's great.
Awesome.
Okay,
Alrighty.
hopefully those are sort of the key points that I was hoping were the takeaway for today. I'm going to ask for questions next. I did read one of them, and it was, can you repeat the 3 Ps, please? So the 3 Ps were past medical history, pain, and poop. So those were the 3 Ps that I talked about. But I'll let Allison go with their.
All right, no problem. We have a whole bunch of questions in here. So can you repeat the guidelines for food consistency?
For food consistency. Oh, yes. So there was an 2017 by Cichero, Cichero, was the development of an international terminology and definitions for texture modified foods and thickening liquids and dysphagia management. And it's called the IDDSI framework. So if you do work in thickened liquids and modified foods, I would highly look into that. It's just a great tool for making sure there's consistency, especially for transitioning children. Good question.
All right. Another question, is there a right answer for mealtime routine?
No, unfortunately, there's not. But I think that when caregivers talk about what's happening, you can see and ask them what's most important to them. So in my practice, I think it's okay for kids not to eat at the table, and that's just my humble opinion. But I feel that the table is a social gathering to be with your peers at school and with your family. And in every culture I know, holidays and celebrations are around food. And I don't want children to not participate in those social gatherings because they don't want the meal. So I talk to families about allowing them to have a lollipop at the table, or allowing them to, have fun dip, or, fun dip is a great tool for tongue lateralization, right? I think that, or just having a Pediasure at the table. So I think when a family talks about what's happening at their meal table, it'll help cue you in. I usually talk with strategies about using a timer, like increasing the time that the child sits at the table from like a minute and going up to 2 minutes. I don't recommend using behaviors like rewards for foods, because I feel like that's it can have great short-term results, but it doesn't necessarily have good long-term results. But I do think using rewards for things like sitting at the table can be really beneficial. So I think it's really talking to them about what is most important to them, what do they want to work on, and I just try to make sure that the child is participating in the social part of meals. I want them to be at whatever holiday they celebrate. I want them to be at the table with their family enjoying that holiday, because it's so much more than the food. And if we focus on the food, they're going to miss out on the rest. Good question.
Do you have tips for introducing solids for infants who are blind?
Oh, I'm thinking of someone I have on caseload right now. So baby food is considered a solid food, so I'm not sure if you mean baby food. A lot of the times we use like playing with food and allowing them to explore with their hands and seeing if they'll bring their hands up to their mouth. For moving off of baby food, like type 1 is mostly watery, and then stage 2 is a little bit thicker, and then I jump right over to veggie straws. I actually have some here. I don't leave home without them for EI, and I know we're not supposed to bring things into the home, but I always bring veggie sticks into the home, because if I want to test if they can chew, I'll use a veggie stick, because I can put the veggie stick sort of laterally right on their molar, and I can see if they can close down, and it's dissolvable. So it's a really safe way to work on the chewing skills. If I'm working on the jaw strength on here, I want to actually use food. So the first food I'm going to try to use when I think it's safe is going to be veggie sticks. I love these things, and they come in different flavors. Like Staples has the apple straws. that are like dissolvable. The only thing I would say is make sure that you or the parent always eats one first. Make sure that they're not stale. These individual bags, you know, in the hospital, it's easy to have them. But if you're in the home and you're using the parents, just make sure that they're not stale, because they're no longer dissolvable when they're stale. But I hope that I answered the question in the way in which you were asking.
What are the main signs that make you decide that what are the main signs that make you decide that the need for immediate intervention?
Immediate intervention. Okay, so if there is anything that looks like it's unsafe, so I carry a pulse ox around, but if you're in a school system or regardless of your setting, some things that you can sort of objective measures, you know, you can have the child's temperature taken before, after, and like an hour after they eat to see if there's a change in temperature. You can use a pulse ox and take their oxygen saturations as well as their respiratory rate, and look at it before, get a baseline during their food feeding, and then also after, like 20 minutes after, and you can look for any types of changes. You can look for coughing, burping, excessive burping. You can look to see if there's watery eyes. You can see if there's real big behaviors around mealtime. That's a sign that there could be pain. Arching the back or turning the head sometimes during mealtime, that could be a sign of reflux. So if there's any of these red flags, you know, I'm going to be very concerned. And so I'm going to sort of step in if I think there's any kinds of showing of aspiration, reflux, if the child eats less than 10 foods, if the child is taking longer than 20 minutes to eat. If you think about when working in the public schools for 12 years, the kids have 20 minutes to eat. And sometimes we would get chicken on a bone, and the paraprofessionals would spend literally like a half an hour while the kids were at recess, taking all the meat off the bone, cutting it up, and half the kids didn't have the ability to even chew that chicken meat. So it's like, can we get a blender in here? There's just so many problems. But how long does it take to get for the child to actually chew the food that's in front of them? Do they have enough time, and you know, and are they burning more calories to eat the food? So these are some of the red flags that I look for.
Right. I have a seven and a half year old with autism that takes a deep breath before each bite. Why? There's no history of allergies, asthma, etc.
Are they showing any signs of stress? So sometimes we, especially children, have different strategies where maybe they finger splay. So if you see a child like finger splay at all, or if you see them start to change color at all here, or you see them sort of like a little accessory breathing, these are all signs of stress. And so maybe that child is experiencing possibly some stress before eating. I'm not sure, but what I would look at their sort of their overall picture, and do they look stressed when it goes to eat? Is it something that is stressful for them? But I'm not sure, to be honest.
All right. If a child has a high narrow palate due to pure Robin, but is able to achieve lip closure and tongue is not restricted, this is going to impact on positive pressure. Is that right? How do we help with this?
Yeah, so there are some exercises for a high palate. You could email me afterwards and we can talk about that. I haven't worked with a high palate in a really long time, so I don't want to say misinformation, but I have information in my books that I could look at. But yes, a high palate can cause difficulty with speed of bolus propulsion.
Okay. How do you suggest working on a child who refuses to take a bite? He has no chew skills and will pocket things in his cheek until it dissolves or it's soft enough to chew.
He won't take a bite. So how is the food getting in there that that is being pocketed. So if he's pocketing food, it really means he doesn't have the skill level for whatever he's being given. So if you're pocketing food, you really want to back up to stage food, baby food, and maybe just do dissolvables like the chew sticks, and really work on strengthening to make sure that you're having the oral motor skills necessary for food, because we don't want to be in a situation where we're giving kids more advanced foods than the skill levels that they have. So I might back up a little bit and see if the child is more successful.
Okay, how fast or what rate should a bolus be formed?
Ooh, that information is actually, I have that, like the exact number in my Vital Stim manual. If you want to email me afterwards, I can get that information for you, but very quick.
Okay, so there is a couple questions coming in on how to assess strength. Can you review some of that?
So as I said in my presentation, I use the Beckman Oral Motor Protocol to assess strength, and that's basically palpitation. So just like you would assess a muscle strength for your upper extremities, we palpate the muscles using the Beckman Oral Motor Protocol, and that's how I assess muscle strength. So if you don't have a way that you do it, I don't have permission to teach Beckman. I've been working on it for some time, but I don't have that yet. She doesn't have like a train the trainer model. But if you don't know where to start, I really recommend her conference. There are other books out there. Diane Barr has an assessment book on oral motor. Speech therapists, they have books out there. So I'm not a speech therapist, I'm sorry. But I palpate the muscles. That's how I assess strength using the Beckman.
All right, do you know if any of these screening tools come in Spanish?
Ooh, great question. I don't, but that is a very worthy project. And if you email me, I have some Spanish speaking students, and I think that would be a fantastic project. So email me and maybe we'll work on that if they don't come in Spanish.
All right, and could you explain how to do the gum massage?
Yes, so when you glove up your finger, you're gonna come around like the top and come around the bottom. So you're just really coming around. And what I find is that if the gag reflex is still sort of in the front of the mouth, we really want to normalize that and have it pushed back. And so if you start having the parents, as part of brushing teeth or just building it into their routine, if you just have the parents sort of put their very clean, no nailed finger, or if they have gloves, and just sort of go with their finger at the top, this will get looser and looser, the skin. They won't keep pulling in their cheeks so tight to their gum. And so you just really want to test that when you're able to get your fingers in their mouths.
Okay, and can you go over the difference between type 1 and type 2 muscles?
Yes, so your type 1 muscle fibers are your endurance muscle fibers. So I go for a run, I run 2 to 3 miles a bunch of times. I'm not getting any stronger, right? Because nothing's being fired. Now, if I were to all of a sudden, I'm doing my normal 3-mile run and all of a sudden I started sprinting, then I would activate my type 2 muscle fibers. And this would cause me to start increasing my strength because I'm activating my type 2 muscle fibers. So your type 2 are your power. You need them for strength and power. So whenever you fire a muscle, you're always firing you're activating your type 1 muscle fibers first, and then if you need them for strength, doing a pull-up on a pull-up bar, if you need that extra strength or power, speed, then you'll activate the type 2 muscle fibers. And so I believe over 80% of the muscles that you need for swallowing are type 2 muscle fibers. So we really want to look at our treatment approach using that mindset of, I have to keep continuously challenging this patient, this child in front of me, or I'm really not going to see progress because I'm not activating the right muscle fibers.
All right, and what is the youngest age that it's okay to use a Z5 for? Is it okay with a 2 to 3 month?
Yeah, as long as there isn't any issues You know, I'm not, if you would do a chart review, but yes, you could use vibration with a very young child, as long as there's no issues.
Do you use different size straws, different size diameters, or does that not matter?
It does matter. Actually, the thicker, the bigger round, like a Dunkin' Donuts or a McDonald's straw, is really much wider than much other straws like that you would buy. And if you cut those, it's even easier. So you could cut the straw like in half, and it'll help a child be much more successful, versus like the coffee stir straw is much smaller, and so it's much harder to drink out of. So yeah, the width of the straw really does make a difference. And if the child is still having difficulty, you can cut the straw in half. Like the little bathroom cups are really short, so if you really want the child to be successful, you could use a little cup and cut the straw so that they're more successful.
Is it good to use cueing as a technique for lip closure?
I do whatever the child needs to be successful. So I'll use physical facilitation, I'll use cueing. I think that we need to, depending on the child in front of us, we need to use all the tricks we can so that they learn the skill that we want them to. We just need to know, we need to document that. Whatever we did, we need to document.
All right, can you demonstrate the lip press?
You know, I did not bring out a tongue depressor, but I'll use my ruler. Imagine that this was a tongue depressor and I have strawberry and say raspberry, and I'm like, which one do you want? And we'll go with strawberry. And I would put money taped on the side, so maybe a penny here and a penny here. And I used to write the child's name on the back and keep it in a little Ziploc baggie, especially in the school system. But you would put it between the child's, so closed it, sticker it. This is going to be recorded. And so you would have the child hold it for as long as they can. You want to work up to 20 seconds. So you're writing down, you know, so if you have a penny on each end, 2 pennies lip press for 4 seconds. And then they come in the next time and it's 15 seconds, and then they get to 20, and then you put 2 pennies on each end. So you're continuing to increase the resistance, challenging the patient. And yeah, I hope that answers your question.
All right, do you have any suggestions on how to keep kids from swallowing gum?
Okay, so the Talk Tools Gum program is really fantastic, and I use that program, and it's really great. But the gist of the program is, and I'll keep going after this question to make sure I get through the rest of my slides, but really the point is that the child can have as much gum as they want. So the first few times that you're offering gum to the child, you teaching them to spit it out, and then you're offering them another piece, and then they spit it out, and you know, you're timing it like every 10 seconds, and you spit it out and you offer them another piece. So they know they can have as much gum as they want, they just have to spit it out. And so I've been using this program since I learned about it, and it's been really great for parents. For parents who aren't gum chewers, I think that it's a little more challenging, but for caregivers who are gum chewers, it's fantastic. I'm gonna just fly through the rest of these slides here because we only have 5 more minutes, and then if there's time, we can do questions at the end. I just wanted to provide some continuing education. If you're new in practice and you're really not sure where to start, the Beckman Oral Motor Continuing Education Conference is really wonderful. Talk Tools is amazing, especially if you're working in the school system or you're outpatient and you're working with kids who are cognitively able to follow directions. They have really great continuing ed. The SOS program that K2Me does, if you're working with children with autism or mostly with kids who are picky eaters, sensory issues, this is the conference for you. It is fantastic. If you're working with kids with physical disabilities, VitalStim is, I highly recommend learning how to use an MES in your practice. It's really a great conference. So again, this is Beckman. This is Talk Tools. I like to put people's names, pictures with the names, just in case you ever see them, you know that that's them. The Homemade Blended Formula Handbook, which I had talked about earlier by Marcia Duncline and Suzanne Evan Morris, is a great resource if you're working with that more physical disabilities population or with children with G-tubes. No Tube is another They are an international company that really works with families. So just letting caregivers know that this is an option out there, not necessarily that you would be doing it, but you would just be educating families that this is an option. I included some reference books here. Again, if you're new to practice and you're not really sure where to start, here's some of like the Bibles of feeding, I would say for me, are these books that I'm posting here. Lip Prints has a lot of really great ideas, and this tips and techniques really teaching you how to use a Z-Vibe. And the rest is just references. But I just want to make sure that I got through those. And if you have questions, please feel free to email me. I'm always a resource, and I don't mind if you have a specific case and you want to talk about it. I really don't mind if you email. Okay. Any other questions?
All right, we still have a whole bunch of questions. Maybe we can work our way through some of them. And then for the ones that we don't get to, I see your emails listed there, so that's super helpful. I think there was a couple questions around using the organza bag. Is that something that you're giving to the child? How do you keep it closed? Can you explain that a little bit more?
Sure. So I cut the polyester organza comes like in a yard of fabric that you would buy like any other fabric. And I cut the polyester organza into squares. And we'll just pretend that one of these sparkle balls here is a piece of food. I would sort of wrap the food into the polyester organza and just allow the child to really chew on that. So I don't give the poly organza to the child. I give it to the parents for them, but I will show them how to do it first in practice with me so that they feel comfortable doing that. And then I'll leave some polyester organza for them and then sort of see what they thought. Did they use it? Did they want more? It's really so inexpensive that it's one of those things I really don't mind giving away. But for families that were going to use it all the time, they do come commercially available.
All right, and would you do the tongue lateralization activities with the tongue just inside the mouth, or both inside and poking out of the mouth?
Oh, good question. So I do it inside of the mouth because I really want that retraction with lateralization. And a lot of the kids that I'm working with have that protrusion already because they're still on the bottle or still on a sippy cup, and they really need the retraction. So I'm not going to encourage any outside of the mouth activities. I just would mention, I do carry Fun Dip with me all the time. It's a really great tool again, and the kids really like dipping the stick in. You know, you lick the stick and then you dip it in the Fun Dip and going from side to side. And any of these activities that you do with the child, I always let the parents video me. I just ask them that they try to get a lot less of me and more of the child as possible so that they can feel comfortable. If the parent doesn't feel comfortable necessarily taking over in that session, which is ideal, so I video the parent doing it with the child right then and there. But if that's not always possible, I'll have I'll allow the parent to video me so that they have that reference when they get home. So just keep in mind that most you know, even in very low income neighborhoods, parents have phones, and so they might not always have data to add apps or things, but they can usually take a video of what you're doing, so they have that as a resource for after you leave, that you can sort of have this home exercise program on an iPad or on their phone for a future reference.
Okay, I think we're going to end there. We're about out of time.